Clinical Virology Part 3. So Picornaviridae is one of the largest families of viruses, more than 280 members. Important for human clinical significance: enterovirus, hepatovirus, including HAV, rhinovirus, and paracheovirus. Enteroviruses are small, naked viruses that cause various conditions, including the ones listed below. They have also been implicated in early onset diabetes, cardiomyopathy, and fetal malformations. Most serotypes are distributed worldwide, occur mostly in the summer and early fall. Infections are more prevalent in areas with poverty, overcrowding, poor hygiene, and poor sanitation. Modes of transmission: aerosol inhalation, fecal oral, and fomites. Portal of entry is the alimentary canal via the mouth. Viruses replicate in lymphoid tissue of the pharynx and gut, may result in viremia, and virus spread to the spinal cord, heart, or skin. Enteroviruses' clinical manifestations: neurologic, respiratory, or cardiac symptoms, depends on viral spreading and the immune state of the patient. Enterovirus infections most often cause mild nausea and diarrhea in adults. However, disease can be much more sensitive in neonates because of the immaturity of their immune system. Polioviruses, clinical manifestations. Polioviruses tend to infect the central nervous system and cause paralysis in a small percentage of infected individuals. The viruses destroy their host cells. In the intestines, damage is temporary because the cells lining the gut are rapidly replaced. In contrast, neurons are not replaced, which results in neuron death and permanent paralysis. No vaccines are available for enteroviruses other than the poliovirus. Good personal and healthcare facility hygiene and proper sanitation can reduce the incidence of enterovirus infections. Polio vaccines of attenuated or inactivated viruses are available. Diagnosis: specimens of choice are listed here. And I'm going to just talk a little bit more about poliovirus. So poliovirus tends to cause flaccid paralysis. So flaccid paralysis means that you can't move it, but you can feel it. So temporary paralysis, usually the virus then clears from the body, or it stays dormant for a really long time in the body. But if this flaccid paralysis impacts a major organ or the ability to breathe, this can cause death, and there has been a significant reported number of deaths in the past. Now, we have essentially eradicated poliovirus from the United States, but there's certain parts of the world where polio is still common and you still see that flaccid paralysis. Now, if a person does recover from polio, they can develop something called post-polio syndrome later on in life, where you have a resurgence of the virus and resurgence of symptoms. Post-polio syndrome can also cause death. So it's really important to get vaccinated and get vaccinated during the normal course where you're supposed to get vaccinated. So moving on to Coxsackie virus, hand, foot, and mouth disease. So primary types are listed: transmission by fecal oral route or by fomites. Symptoms: malaise, headache, abdominal pain, small painful sores on the tongue, buccal mucosa, and soft palate, and macular papular rash on the hands, feet, and buttocks, bullae on the hands and soles of feet. So these symptoms are pretty diagnostic. Usually we don't do any follow-up laboratory testing. The physician will look and say, oh, yep, you've got lesions on the hands, on the feet, and inside the mouth, and they diagnose that way. Can cause high fever. So my son ended up getting hand, foot, and mouth disease, and it's extremely rare for an adult to get it, but I ended up getting hand, foot, and mouth disease from my son. Now, when I got it, I was pregnant with my daughter, and the high fever that was spiked ended up causing the death of my daughter. So I ended up having a miscarriage at 12 weeks of gestation due to hand, foot, and mouth disease. So this is my least favorite thing to talk about, just because the high fever, it was over 104 for like 3 consecutive days, ended up terminating my pregnancy. So really difficult thing to experience and go through. And yeah, so Coxsackie virus, typically they don't talk about that as a side effect, but with any virus, if you get certain viral infections for the first time while you're pregnant and you have an increase in like body temperature, so you get prolonged fever for a period of time, it can lead to miscarriage or loss of the baby. Diagnosis of poliovirus, type B Coxsackie virus, and echoviruses grow readily in several cell lines. The cytopathic effects appear quickly and is readily identifiable. Enteroviruses have no group antigen, so they must be identified individually by serum neutralization test. The virus can be isolated from specimens from swabs of the mouth and bullae. Coxsackie virus grows in PMK and human diploid fibroblast cells and can be identified by serum neutralization tests. Rhinoviruses. So rhinoviruses cause the common cold. They infect nasal epithelial cells, transmitted mostly via aerosols, nasal congestion, runny nose, all of the common symptoms of the common cold. Generally increased incidence during winter and spring. Unfortunately, there's no cure for the common cold. Treating symptoms and reducing the spread of the virus in the household is the typical response. Retroviridae. Members of this group, known as retroviruses, have a unique mode of replication. They require an RNA-dependent DNA polymerase, reverse transcriptase, to synthesize DNA from the RNA genome. So the virus itself has RNA, and then they reverse transcribe their RNA into DNA in the host cell. So now you've got complementary DNA to the viral RNA that has been created inside of the host cell. These viruses are not cytolytic but are associated with several leukemias, sarcomas, and lymphomas. Oncovirinae, human T lymphotropic virus 125, cause leukemias, sarcomas, and lymphomas. Lentivirinae, human immunodeficiency virus 1, and HIV 2. HIV. So the virus is transmitted by blood and the exchange of other body fluids. HIV is cell-associated, so fewer viruses are found in cell-free plasma than in whole blood, and even fewer viruses are found in saliva, tears, urine, or breast milk. HIV is not highly contagious, and normal social non-sexual contact poses no threat to individuals. High risk for contracting the virus includes unprotected sex with multiple partners, IV drug abuse, infusion of blood and blood products, presence of viruses in pregnant women who pass it to the fetus during pregnancy. Individuals with ulcerative sexually transmitted infections like syphilis, genital herpes, chancroid have an increased risk the virus could enter the body through those sores. Donor blood and blood products are screened for HIV, which substantially reduces the risk. This is a diagram of HIV. Once HIV enters the body, the primary target cells are CD4 positive T cells, monocytes, and macrophages. Huge problem. They're infecting your immune cells. Acute infections generally mild and can resemble infections or infectious mononucleosis. Patients will enter clinical latency, where the virus is in the background, rapidly replicating in lymphoid tissue but not detectable in the bloodstream. The patient remains asymptomatic. Eventually, lymphopenia results with the greatest loss in the CD4 positive T cell population. Healthy individuals have CD4 counts as 1,000 per millimeters cubed, where patients with HIV can have counts lower than 200 millimeters cubed. Lymph nodes become enlarged and hyperplastic. The virus destroys helper T cells that are critical in the immune response to infectious agents. Patient begins to experience severe chronic and recurrent infections. With time, the CD4 cell count drops, and opportunistic infections become more severe. If you don't have a fully functioning immune system, you typically can develop those opportunistic infections that normal immunocompetent individuals wouldn't develop. So you don't necessarily die of the HIV itself, you die of the secondary infections, the opportunistic infections that are allowed to develop because your immune system has been weakened. HIV-1 can directly cause encephalitis and dementia. Common opportunistic infections and cancers in patients with acquired immunodeficiency syndrome are listed here. Clinical manifestations in adult patients living in developed countries. The average length of time from HIV infection to development of AIDS is about 10 years. About 20% develop AIDS within 5 years, and fewer than 5% have an asymptomatic HIV infection for periods longer than 10 years. The rate at which the virus multiplies in the host is related to the onset of AIDS. Diagnosis is generally based on demonstration of anti-HIV antibodies and, in some cases, detection of viral antigens and RNA. HIV viral load assay is a quantitative gene amplification technique that measures the amount of HIV RNA in the plasma of the patient. This is super important to monitor disease progression. So we want to keep the viral load low. And if we are using antiviral treatment and we want to determine if the treatment's working, then we can continuously check the viral load to see if the load is staying low. If the viral load starts to increase, then we know that our antiviral treatment's not working. Current CDC guidelines recommend using a screening test that detects HIV-1, 2, and antibodies and P24 antigen. If all those are negative, then no further testing is required. A positive NAT indicates an acute HIV infection. A specimen with a negative NAT should be referred for testing with a different validated supplemental HIV-2 test, antibody test, or NAT, or repeated testing in 2 to 4 weeks. Western blot was the reference method for HIV diagnosis for years. Viruses are grown in cell culture, lysed, and proteins are separated by electrophoresis and then transferred to nitrocellulose. Antibodies to several HIV proteins and glycoproteins can be detected. For a positive result, CDC guidelines are listed. Western blot reports should also be followed by tests for anti-HIV-2 antibodies. So that's what an immunoblot looks like. Treatment. Because these viruses readily develop resistance to drugs, HIV infection is often treated with combination therapy, very much like when we talked about Plasmodium falciparum. We talked about artemisinin combined therapy because of how resistant Plasmodium is. The thing about HIV, though, is it rapidly divides, and a lot of mistakes can be made when the host cells are replicating its genome. So HIV is RNA. It reverse transcribes itself back into DNA inside of your host cells. And then it tells your host cells to make more viral copies. So it copies the DNA. Through the reverse transcription process and then the forward transcribing of the viral proteins, a lot of errors can happen through that process. So this thing mutates quite a bit. Despite aggressive therapy, a cure is not achieved. There are several classes of antiviral drugs approved for treatment, and treatment is pretty effective these days. So if treatment is begun early, the likelihood that a positive mother transmitting it to the baby is really low. So babies are born essentially without an immune system, and they develop their immune system within like 6 months after life. That's why breastfeeding infants is so vitally important to get that initial immunity from the mom's antibodies. But HIV can be transmitted in utero, and if the baby is born vaginally, there's a whole bunch of fluid that's exchanged between the mom and the baby, so babies can have the virus inside of their bloodstream. The good thing, though, is because they don't have a full assembly of T cells yet, the likelihood that they're going to get infected is low. And then if you treat them with antivirals early, you can achieve almost 100% chance that they're not going to get infected from a positive mom. We want to maintain the viral load as being low, so a lot of the treatments today are focused around keeping that viral load low. And if the viral load is low, the likelihood of transmission is also low. And that's kind of what this talks about here. Rhabdoviruses. Rhabdoviridae, the genus Lyssavirus, causes rabies. Cases of rabies are rare in the United States. Worldwide, dogs are implicated in 99% of rabies deaths among humans. Rabies is an emerging infection in animals. Transmission to humans, bite or scratch by animals with rabies. So this virus tends to accumulate in the salivary glands and is transmitted through saliva, infected saliva. Lots of different animals can carry this, and there's a significant concern of dogs particularly bringing rabies up from the southern United States or across the Mexico-United States border. So because of that concern, what they do is they create these rabies vaccine biscuits, and then they dump them all over the southern U.S. border. When I was living in Texas, I actually saw a plane fly over, and these got dumped all over my ranch, and it was pretty crazy. I had heard that they were doing this, but actually seeing these little biscuits get dropped was pretty insane. So they're biscuits, they're super smelly. Usually they put like fish oil on them or something that's going to entice a lot of different carnivorous animals to consume it. And then they're vaccinated, and they can consume a lot of them without getting over vaccinated. So that's kind of a good thing. But then that reduces the likelihood that wild animals and feral dogs are going to be transmitting this through the bites. Animals that are infected tend to have decreased cognitive function, so they lose their fear of humans and they start to become super friendly, particularly raccoons. They'll start to come around more, they'll start to act a little bit friendly and kind. You think you can approach them and touch them, and then all of a sudden you get bit and you get infected. Once you're infected, you got about a month to go seek treatment before symptoms are going to develop from this. Prophylaxis is key. So the second you get bit, you're going to want to go to a healthcare facility and get the wound flushed out and then get vaccinated. So if you get vaccinated on the day you get bit, you're going to develop your own antibodies and immunity against the virus before the virus has a chance to actually replicate enough to show symptoms. Once a person develops symptoms, it's like 100% fatal. So it's really important to do the prophylactic steps. And like I said, you've got about 40 days, depending on the individual incubation periods, between 30 to 60 days. We say about 40 days on average to go get that prophylaxis and get the immunity developed before you show symptoms. So brief prodromal pain and exposure site, vague flu-like symptoms. Mental status changes such as anxiety, irritability, and depression can also occur. After the prodromal period, CNS changes involving hallucinations, paralysis, excessive salivation, hydrophobia, bouts of terror, seizures, respiratory and cardiac problems leads to coma and death. These symptoms are followed ultimately, like it says, by coma and death. Diagnosis involves determining whether the animal that has bitten has rabies. So the animal is usually killed, the head's removed, and sent to a reference laboratory. I actually interviewed for a position with the United States Army at a facility down in Texas where they were doing this rabies testing. So we would receive the severed heads of animals and do the investigation. I declined the position. I could not deal with animal heads all day long. I thought it was more of a cell culture type approach, but nope, they were receiving animal heads and I couldn't do it. The fastest and most sensitive method for identifying rabies virus in a specimen is by using a direct immunofluorescence technique. Impression smears should be made from various areas of the brain, primarily the hippocampus, pons, cerebellum, and medulla oblongata. In living patients suspected of having rabies, skin biopsy, especially at the hairline and back of neck, and an impression of the cornea may be performed. The presence of rabies virus in these specimens is diagnostic, but its absence merely means that no virus is present in those specific specimens at that particular time, not that the patient doesn't have rabies. EIAs are currently the most sensitive assays to use. Treatment must occur prior to symptoms. It cannot be treated successfully once symptoms appear. Post-exposure prophylaxis, 100% effective, and that's what I talked about. You clean the wound, provide human rabies immunoglobulin, and administer the vaccine. The vaccine can be given to those at risk for exposure: veterinarians, laboratory personnel, wildlife folks. Members in the family Togaviridae, the alpha virus, Eastern equine encephalitis, Western equine encephalitis, Venezuelan equine encephalitis, and rubella virus is in the rubevirus. EEE natural reservoirs are birds. Mode of transmission would be mosquito bite, occurs primarily in the eastern half of the United States, hence Eastern equine encephalitis. Causes diseases in horses and humans. Dead end hosts, EEE in horses, can be a predictor of human EE cases. Range of symptoms, mild flu-like to encephalitis. Young children and infants who survive, 5 to 30% will suffer permanent CNS damage. Mortality is about 3%. The Venezuelan, and cases of the Western equine encephalitis are milder of a disease than EEE. Venezuelan equine encephalitis has caused large outbreaks of human and horse encephalitis in the Americas. Death is much more common than EEE or WEE. Between 4 and 14% of infected individuals will develop neurologic disease. Infected adults often develop flu-like illness, whereas encephalitis is more commonly seen in children with VEE. Rubella virus belongs to the genus Rubevirus, causative agent of rubella or German measles. Mild febrile illness transmitted by respiratory droplets. The virus is present in naropharyngeal secretions or any secretions of infected infants, and this typically goes away on its own. You get a little bit of a rash and fever, and it's mild and it goes away. The rash starts on the face and spreads to the trunk and limbs. No rash appears on the palms and soles. Transient polyarthralgia and polyarthritis can occur in children and are common in adults. About 50% of those infected with rubella virus are asymptomatic. Rubella would be of little concern if it did not cross the placenta, but it does, which results in congenital rubella syndrome. The syndrome can cause effects ranging from birth of a normal infant to birth of a severely impaired infant, fetal death, or the spontaneous abortion. Virus halts or slows cell growth. Impact on the embryo is worse when infection develops in the earliest stages of pregnancy. An effective attenuated vaccine is available. In 2004, the CDC declared the United States rubella-free, meaning an absence of continuous disease transmission for 12 months or more. Diagnosis: it's important to collect specimens like throat swabs the day the rash appears. To date, no protocol for detecting viral RNA has been established. Isolation procedures are difficult because of the lack of a cell line that exhibits a cytopathic effect. Serological procedures are effective because any rubella antibody is presumed to be protective. The most sensitive serological assay are solid phase and passive hemagglutination tests. Latex agglutination and antigen-coded red blood cell tests are useful but less sensitive. So now we're going to get into the human hepatitis viruses. So a lot of times these are also covered in like clinical chemistry classes because clinical chemistry evaluates the levels of different things in the blood. These can also be covered in an immunology course because typically diagnosis of these guys is immunological based. So some of this you may have heard before. We're just going to briefly go through the different types of hepatitis viruses and talk a bit about how they're diagnosed. So just want to briefly go through these as they're listed here. Hepatitis A is more of a digestive tract infection. So foodborne, waterborne, fecal oral route causes diarrhea that is self-limited. All of these cause inflammation of the liver. That's why they're all classified as hepatitis. But hepatitis A will cause a little bit of a hepatomegaly, a little bit of liver swelling, and then it kind of goes away. It's usually a self-limited type infection. Hepatitis A, there is a vaccine. Hepatitis B, there's a vaccine. And hepatitis C, there's a new vaccine that's available. Hepatitis B can be a little bit more serious. Hepatitis B has a high association with needle stick and blood contact, using dirty needles when you're a drug addict, transmission of any blood contact and that type of stuff. So it's more of a bloodborne type of contact or intimate contact, transmucosal transfer. Hepatitis B, in a small percentage, can develop hepatitis or chronic inflammation of the liver, which could lead to liver cancer. There is a vaccine that protects against hepatitis B, and usually before you go and work in healthcare, you get vaccinated against hepatitis B. Hepatitis D can only infect you if hepatitis B is already there. Hepatitis B, usual blood contact, and hepatitis B has to be present. Hepatitis C is going to be your usual blood contact and also vertical transmission from mother to baby. Intranasal cocaine use has been associated with hepatitis C. Hepatitis C is the one that has a really long incubation period, normal incubation period, really long period of going dark in the body. So we get infected with hepatitis C, and then it could be like 20 years later before we actually show symptoms of it. Once symptoms develop, it can be a very sudden onset of severe hepatitis and cancer. So general clinical symptoms of these guys, despite biological and morphological differences amongst the hepatitis viruses, many of the clinical symptoms caused by them are similar. Therefore, differentiation based on clinical findings should not be relied on for diagnosis. Most common symptoms are going to be flu-like symptoms with jaundice, dark colored urine. Hepatitis A is an enteric virus, as I mentioned, fecal oral route. Symptoms: mild to severe prolonged hepatitis. Infection is self-limiting with convalescence possibly lasting weeks. Complete recovery can take months. Low mortality rate, no chronic liver damage. Diagnosis: demonstration of IgM to IgG is the most common method. Isolation of hepatitis A virus is not practical. Some labs offer in-house real-time PCR testing to detect HAV before liver enzymes are elevated. Studies have shown that HAV RNA can be detected much earlier after infection. So earlier on in infection, we have anti-HAV IgM, and then IgG confers long-lasting protection. If you go back and think about your immunology class and when in the sequence IgM is present, IgM is usually our first responder. So that's the first antibody that's going to detect an infection being present. IgM is going to be shed from B cells, and then eventually we're going to have that immunoglobulin isotype switching happen. And that's when B cells are going to start switching the type of antibody expression. They're going to convert into plasma cells and start secreting out IgG antibody. IgG can cross the placenta and can cross all over the body, and this is the antibody that's going to remain in high levels to confer protection after exposure. If you do get vaccinated against hepatitis A, you're going to see the IgM response, and then the IgG will provide prolonged protection. Vaccination of children has the potential to reduce the incidence of HAV. Other vaccination target groups are listed here. People who have not been vaccinated and have been exposed to HAV can receive immunoglobulin therapy. It's also used as pre-exposure prophylaxis. Hepatitis B contains hepatitis B surface antigen, and that circulates in the bloodstream as a 22 nanometer particle. Virion also contains hepatitis B core antigen and hepatitis B envelope antigen. 8 genotypes of HBV have been identified. Main modes of transmission: bloodborne pathogens, sexual, vaginal, and saliva. High-risk groups are listed here. Diagnosis is based on clinical presentation and demonstration of specific markers for HBV. Presence of HB surface antigen in patient's serum indicates the patient has or is in an active infection, a long-term carrier, or in an incubation period. So having the surface antigen present means that they actually have the infection at that moment. And then you can review the definitions of these serological markers here. So hepatitis B E antigen is, S antigen is the surface antigen. Anti-hepatitis B-S is an antibody to the antibody hepatitis B surface antigen. Anti-HBC is an antibody against the core antigen. HBe antigen is an antigen associated with the nucleocapsid, and it's also found as a soluble protein in the serum. Anti-HBe antibody to hepatitis B enveloped antigen. Diagnosis: IgM anti-HBC appears early in the course of the disease and indicates an acute infection. In patients whom hepatitis B surface antigen is not detected, an anti-hepatitis B surface protein has not yet appeared. Detection of IgM anti-HBC confirms the diagnosis of acute HBV infection. The period between inability to detect HBs antigen and anti-HBs antibodies is called the core window. The detection of anti-HBs antibodies in serum indicates convalescence or immune status. When infection resolves, IgG, anti-HBC, and anti-HBs antibodies become detectable in the patient's serum. The presence of HBs antigen after 6 months of acute infection is a strong indication that the patient is a long-term carrier. The appearance of HBe antigen in this case is indicative of a chronic infection and high infectivity. So this is a table that kind of helps you interpret the hepatitis B serological markers. And here is a diagram. So here we see anti-HBC IgM. So that appears first and then drops off. Then we see antibodies against the envelope, and then antibodies against the core antigen. And then we can see antibodies against the surface antigen. Hepatitis D, as I mentioned, requires hepatitis B surface antigen as its envelope. Transmission is primarily through parenteral routes. Mucosal contact has been implicated. Risk factors: IV drug users. Rare but usually severe and results in acute disease with fatality rate of 5% or chronic symptoms progressing to cirrhosis in 2/3 of those infected. Two clinical forms: a co-infection, simultaneous infection with HBV and HDV, or a superinfection, where infection develops in a patient with chronic HBV infection. Patients with superinfection have a more severe acute infection and have higher risk of fulminant hepatitis compared with patients with a co-infection. Long-term carriers of HBV who become superinfected with HDV also develop chronic HDV infection, which increases their chance of developing cirrhosis. Diagnosis of HDV infection requires serological testing for specific HDV antibody. Commercial tests are available. Reference laboratories may offer IgM and anti-HDV antibody testing and PCR assay for HDV. And then here you can see the serological markers for hepatitis D virus and serological detection. Hepatitis C is a bloodborne pathogen. Risk factors would be blood exposure. Symptoms may be subtle and take time to present. About 20 to 30 patients with chronic infections develop cirrhosis. Major risk factor for hepatocellular carcinoma, cirrhosis. HCV has the highest mortality rate amongst all of them. So, another side story. A friend of mine, his dad is a cop, or was a cop, and there was an altercation where his dad was arresting someone and the person was beaten in their face by another suspect, and that person had a lot of blood dripping out of their face. The person was resisting arrest by my friend's dad, and the person ended up spitting in my friend's dad's face. And at that time, not a lot was known about hepatitis and the risk factors there. I believe hepatitis B was known about, and not really a lot of information out there about hepatitis C. So my friend's dad thought nothing of it. May or may not have had flu-like symptoms around the time. It was not really something that he paid attention to. The incident was reported and kind of stuck in the back of my friend's dad's mind because there was blood exposure. So there was always just kind of this nagging thought that maybe something happened. Fast forward 25 years from the incident, and suddenly my friend's dad developed severe hepatomegaly, jaundice, severe cirrhosis, and was very close to the development of hepatocellular carcinoma. So the cirrhosis was not to the point of actual cancer, but it was a lot of inflammation in the area, in particular areas of the liver. And there were multiple lesions on the liver that he had this issue. So he was tested and tested positive for hepatitis C. Recently, they developed a vaccine for hepatitis C, and he was given a whole bunch of treatment with antibodies, and I never really was able to follow up on where he's at with his treatment today. I know he's still alive. I did lose touch with my friend, but the treatments that were available back then were not as effective as what's available today. And now, like I mentioned, there is a vaccine that is available for hepatitis C. Diagnosis, molecular testing, and immunological testing. Screening tests, immunological screening tests are available, and nucleic acid amplification tests are available for confirmatory testing. Hepatitis E virus is another fecal-oral route one. Fecal contamination of drinking water causes acute self-limiting diseases that resemble HAV, found in developing countries, no U.S. sources. Clinical manifestations: fever, malaise, nausea, vomiting, jaundice, and dark-colored urine. Diagnosis: immunological tests are available. No specific antiviral therapy is available. Patients usually just get supportive care. Viral shedding in the feces has been shown to persist for several weeks. Prions. So prions are not viruses. They're just small proteins, and they are self-replicating proteins. So they make copies of themselves all by themselves. They're called, or when they cause disease in mammals, they're called transmissible spongiform encephalopathies, or TSEs. Transmissible because they can be spread from one individual to the next through eating infected nervous tissue. And then there has been some other weird associations of how they're transmitted. Spongiform, meaning that they cause a spongy appearance. Encephalopathies, the spongy appearance appears in the brain. So they self-replicate in pockets in the brain and cause holes to appear in the brain. Clinical forms, Kuru and Creutzfeldt-Jakob's disease in humans. Kuru is typically by consuming infected animals, animal tissue, like eating brains from an infected animal. Creutzfeldt-Jakob's disease is an inherited disease. Scrapie in sheep. Sometimes, in order to save money on food, farmers will grind up animals, especially animals that have died or are sick, grind them up and feed them up out to the rest of the animals. Well, if it includes the nervous system tissue that they've ground that up, then they can be transmitting that to all of the animals in their area. Bovine spongiform encephalopathy, BSE, also known as mad cow disease. In mad cow disease, cows are herd animals. So with mad cow disease, you typically see the cow isolating itself from the herd. It has difficulty walking. It often walks with like a drunken gait and it stumbles. When cows are sent to slaughter in the United States, they are forced to be evaluated walking down a long chute. And if they stumble or slip during that process, then they may be checked or assumed to have mad cow disease, and they may be incinerated instead of processed with meat. Chronic wasting disease in deer and elk. So CWD causes the same types of symptoms in cows as in deer, but this one's specific for deer. Causes the animals to, again, develop a staggered walk, and they seem like they're stumbling around drunk. They have difficulty maintaining their balance and posture. And this makes them a lot more prone to being hunted or being killed by predator animals. So in areas where wolf populations are really high, chronic wasting disease is really low. In areas where the wolf population is not so high, you tend to have a lot more chronic wasting disease. If humans consume the brain tissue of an infected deer or cow or any animal, they could potentially get the prion disease. Increase in variant form of CJD was noted at the same time as surge in BSE. It appears that the agent of Scrapie cross-species and infected cows, and that's the causative agent of BSE infected humans, causing a VCJD. TSE is acquired via ingestion. Some prions may enter the body via other routes or may be inherited. Progressive relentless degeneration of the CNS that is ultimately fatal. Diagnosis often based on clinical findings, histopathology stainings, immunostainings, other tests, antigen testing, serological testing, and neurological acid or nucleic acid sequencing. Handling of suspected prion materials. Caution should be used when handling suspected materials because the prions are highly resistant to inactivation. Exposure to household bleach with more than 20,000 parts per million available. Chlorine or 1 molar sodium hydroxide is recommended. Putting it in an autoclave doesn't get rid of the prions. There was a case where a brain surgeon did operations on several people after operating on a person that had prions in their brain and ended up infecting those subsequent people. Even though the tools were sterilized or put in an autoclave, the infectious particles still remained on those instruments, and they ended up infecting a few more people from that. It's not recommended to test any specimens from a suspected case of prion disease until it's ruled out, since instrumentation cannot be sufficiently decontaminated, and it presents a risk of infection to staff. So managing viral infections, viruses have evolved to replicate inside of host cells. Since viruses used host cell machinery to replicate, most drugs targeting viruses have the potential to affect the host cell as well. Viruses with very high mortality rates are often eradicated equally rapidly as the survival of the virus relies on effective transmission in new hosts. Most pathogenic viruses eventually mutate to milder infections and become more contagious. This trend is being observed in the ongoing COVID-19 pandemic. Most Mild viral illnesses are not treated. Instead, supportive care is provided and quarantine is recommended to break the transmission cycle. Some antiviral therapy exists. Some viral infections are treatable, especially if a laboratory can rapidly identify the pathogen. Antiviral compounds must target essential viral replicative mechanisms without destroying or damaging uninfected host cells. The use of antiviral compounds increases the risk of drug resistance, and thus antiviral susceptibility testing will become increasingly important. Here's examples of antiviral compounds. Vaccines, the development of vaccines is key. Vaccines prevent disease, not the infection. So the virus can still infect you, but typically your immune system wipes it out before it progresses to a disease. Several viruses have been responsible for several pandemics, including influenza and coronaviruses. Clinical virology services can consist of rapid antigen detection, NATs, antibody detection, or cell cultures. Clinically significant viruses can be isolated from patients with signs and symptoms commonly thought to be associated with bacterial infections, including pneumonia, GI disorders, cutaneous lesions, sexually transmitted infections, and sepsis. Members of the family Herpesviridae produce lifelong latent infections. Most cases of cervical cancer are linked to HPV, the causative agent of genital warts. Some viruses mutate rapidly, resulting in the new strains, which can be challenging to contain or treat. Retroviruses replicate with reverse transcriptase, which uses viral RNA as a template to make a complementary DNA strand. Arboviruses are those viruses transmitted by the bite of arthropods, such as mosquitoes. Many emerging infections are caused by viral agents that are unexpectedly transmitted into a susceptible human population. The hepatitis viruses are a diverse collection of viruses grouped together because they all infect primarily the liver. Laboratory diagnosis is based on serological markers. Antiviral compounds can treat numerous viral infections, but resistance has been seen. Vaccine against viruses is an effective way to manage viral infections.